welcome. Due to COVID-19 and the Governor's Proclamation 20-28, we're meeting today via Zoom only. Dave's going to talk about this briefly in a moment, but starting in June, we're going to have in-person options for board members and the public to attend the board meetings. We're going to do introductions. I'm going to do roll call. Terry House.
Good morning.
Morning, Terry. Welcome.
Thank you.
Paulson.
Good morning.
Good morning. Pamela Cruz.
Good morning.
Good morning. Carrie Schaefer.
Good morning.
Morning, Carrie. Amy McGuire.
Good morning.
Morning, Amy. Mr. Pete Cutler.
Good morning, everyone.
Morning, Pete. Donna Hanson-Murray.
Good morning.
Morning, Donna. And Dan Gossett.
Good morning, everyone.
Morning, Dan. And we have Katie Hatfield from the AGO.
Hello, everybody. I'm here.
Morning, Katie. And I'm Lou McDermott. I'm the deputy here at HCA and the chair of the SEB Board. With both board members and presenters attending virtually, it'd be helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks for questions. Board members will be watching for your Zoom hand to indicate that you have a question as well. And the public's going to have an opportunity to provide general comments at the end of the meeting during the public comment period. Dave's going to give us an overview of the agenda.
Right. Good morning, Chair McDermott, members of the board. Today we are going to pick up on the conversation that we had last meeting about specific uniform dental plan benefit design options as the agency prepares a decision package this summer for consideration in the upcoming biannual budget processes. And so I'm hoping that there's been some reflection. We wanted to share how the conversation went with the SEB Board at its last meeting, as we're having similar conversations and presentations on this topic. Then we will wanted to begin a little bit of discussion on the vision benefit design. We did a survey earlier this year of SEB and SEB members and wanted to share the results of that and start to begin having a little bit of an eye towards potential vision prioritization of different benefit design options within the vision part of the portfolio. Then we're going to move into a little bit of discussions about some upcoming procurements that are happening from my division and the agency related to some of the benefits within the portfolio. And so I wanted to give you some, you've heard a little bit about this, breadcrumbs from Tanya and myself as part of the supplemental budget processes, a decision package that supports procurement activities. And so we wanted to give you information about some of those upcoming procurements. So we'll be talking about FSA and DCAP, and then wellness, and include just a general update about the Smart Health program at the same time. Then we'll end with public comment and go into an important executive session where we begin talking a bit more about what is happening in the rate negotiation process for the annual renewal. So relatively short public meeting, and then we'll move into the executive session. I do want to highlight that the agency's background today is the crossing between Grant and Kittitas County near Vantage, Washington, just another beautiful scene from our state, crossing the Columbia River as you head west on I-90. Lou mentioned at the beginning that this is set up to be our last all virtual meeting. In the future, starting with the June 2nd SEB Board meeting, we will be transitioning to hybrid board meetings, which essentially means that we will have a physical space here at the Healthcare Authority in Olympia, much like pre-pandemic days for board members who were members of the board before the pandemic hit, where we meet in the bottom, the first floor of the building, and there's space for the public to attend in person too. But we will continue to support remote access, and the remote access will be more similar to what you're experiencing today and have for the last 2 years than the audio-only version that existed before the pandemic. There's not going to be a requirement for board members to attend in person. You'll have that opportunity and that option if you want. Same goes for the public. So we'll have a little bit more differences in how we manage the meeting, because before we generally managed in a room. For the last 2 years, we've generally managed online, and now we'll be doing two things at the same time. So we're working on how some of that will exactly play out from a management aspect. But starting in June, you will have the option of coming in person, and I will reach out to you with some more information. But if you are planning to attend in person, we would want to know that just so we can kind of adequately prepare. And just for everyone's awareness, here at HCA, the staff, when we're interacting on the public spaces where this meeting will be held in the future, staff are expected to wear masks for when we're serving the public in that public space. And so I just wanted you to be aware that if you come to the building, you will experience staff wearing masks at this point. I think that is all that I wanted to share at the moment. And I will turn it back to you, Lou, unless there's any questions.
Any questions from the board? All right, seeing none, our first agenda item is the 2024 Uniform Dental Plan Benefit Design Options. Ellen Wolfhagen, Senior Account Manager in the ERB Division, will follow up from April's meeting and review design options that could lead to changes in 2024. Her materials behind tab number 3. Welcome, Ellen. I think.
Good morning, Chair
Good morning.
McDermott and members of the board. I hope that you can hear me now.
Yes, we can.
Okay, great. Next slide, please. As Chair McDermott said, this is a follow-up from the April meeting. We're going to review some of the specific proposals that have been presented before for potential enhancements for the Uniform Dental Plan, UDP, and we'll provide some relative financial impacts to help guide the prioritization discussion. Next slide, please. Next slide. So one of the questions that came up is, what is the difference between preferred providers in the network and premier providers? They're both providers under the Delta network, but the coverage is different. The contracted rate for preferred providers is more favorable for both the members and the plan. There are about 3,800 PPO providers, preferred providers within Washington State, and 4,200 premier providers. As you can see, the percentage of coverage is less for premier providers. So we encourage people to use preferred providers to get the most benefits for the members themselves and also for the plan. I do want to note class 2 includes periodontia, root canals, oral surgery, as well as fillings. And class 3 includes crowns, bridges, and implants and other very major dental services. Next slide, please. Just as a reminder, these are the benefit proposals that we're talking about: an annual plan maximum adjustment, covering composite posterior fillings to the same percentage of coverage as amalgam fillings, an incentive plan design that promotes preventive services, no deductible for children's benefits, and TMJ lifetime benefit adjustment. Now, I'd like to transition to a discussion of crown coverage, which was raised at the last SEB board meeting. Next slide, please. We did a little market comparison similar to the other benefit design enhancements, comparing the current plan to the Delta book of business. This is large employers. And the WEA plan that was pre-SEB. As you can see, it's most common to have 50% coverage, such as in UDP. The pre-SEB plan was extraordinarily generous, and it did depend on dental visits in the previous year. Next slide, please.
Ellen, this is Dave. I just wanted to add for additional context, just happened to be at a conference with other state and local government associations this week here in Seattle. And one of the things, as I was just getting to know some of my state counterparts, one of the things that I was asking them was about crowns, since it was top of mind knowing I was going to this board meeting. And I wanted to let you know that the five or six states that I talked to about some of their dental plan coverage was similarly having 50% coverage for crowns. So just took the opportunity to verbally ask some of my counterparts what their crown coverage was while I had them at the same table, so to speak. So just wanted to add that additional context from that experience
Thank you, Deb. So this slide is the potential cost impacts to the per subscriber per month premium rates. There's a couple of things to note. The crowns are currently in class 3 for both preferred and premier providers. And all of the examples, so if we went to 60% for preferred, it would be 50% for premier, and all of the other examples reflect a 10% lower coverage for premier providers. So when we look at the increase to a 60% coverage level, it's more than 225 cost impact. And that's more than any of the other 5 individual options that have been presented. The increase to 70%, which is about $4, is at the lower end of the cost for all 5 other options combined. And an increase to 80% is higher than the end cost for all of the other options combined. Dave, do you want to provide any additional insights here?
Yeah, we'll remind you in a couple of slides about the overall macro financial picture, but I know that Crowns has, at the last board meeting, it was very clear that there was an interest in learning more about Crown coverage. And we've tried to show some relative cost information. We said, and we knew here that the answer was going to be that it is expensive to expand Crown access. But it is important to we decided when the numbers came back the way they did to show it relative to the rest of the proposals. And it's quite stark in comparison that, effectively it would set up the dynamic of would there be an interest in doing any and all of the other things that have already been presented over at the last board meeting, or something like Crown. As we get a little bit further into slides, remember, I'll remind the board about what it means for the state budget range implications of, $4 or $5 or $7 PSPM, and the magnitude and how that quickly balloons. It's something like the Crown proposal would cost anywhere in the realm around like $15 or more million on an annual basis for the 2 programs. So it's important just to keep that context. Anyone can have any different prioritizations, but it is a stark comparison that the cost of just this one Crown type proposal, depending on, what one might desire to have as the preferred outcome, is essentially the same cost of the entirety of the other 5 proposals that have already been presented.
I'd like to pause at this point and see if there's any questions before we move on to prioritization. Hearing none, let's move on. Next slide.
Actually, Ellen, I see a question from Pam.
Oh, I'm sorry.
I'm not sure if this is a question or a comment, but when speaking with our members, we are talking about increasing benefits, especially WM members. We're so used to having an extremely rich benefit option, especially in dental. And I'm a little worried about the perception of, well, others don't do it, so we shouldn't. I'm thinking more of educators, deserve a right to a rich benefit plan, and not to steer away from something just because other large employers don't do it. So maybe if we focus more on what we can get for our members, the best possible coverage and the richest plan possible. Thank you.
Yeah, I know that wasn't really a question, but I just wanted to provide a little additional context. We do a lot of benchmarking because there's parts of the portfolio that and some of the other platform or planks that we've shown where the benefit design is behind the market, and then there's other places where we're ahead of the market. So it's certainly not to say don't do something because others aren't doing it, but it's just we like to give the context of where the benefit design in any part of the portfolio is behind the market, because that represents a potential advantage to a competitor in a recruitment and retention perspective of why benefit design exists or benefit offerings exist within the hiring processes of employer. And there's certainly parts where we're ahead of the curve with the market. And so we usually just describe what's happening in the market, not to say don't do that because it's not ahead, but so that we're all aware as to like where we're market leaders and where we're market followers. So just wanted to throw that out as apologize if the perception was coming that we shouldn't do something because others aren't. It's more just the context of where we're a market leader or where we're a market follower.
Appreciate that.
I can't see if there's any further questions.
I think you can proceed, Ellen.
Okay, thank you. Next slide, please. So we're going to move into the prioritization discussion. And as you may recall, we're looking for guidance from the board on how to move forward with these different design options as we prepare a decision package for the legislature. Dave, do you want to add any information here?
Yeah, there was a question in public comment last meeting that I thought would be a good one to illustrate. So these 5 proposals, there's 3 that are talked about on this slide and 2 on the next slide. And the important context that Ellen gave last meeting was that for each of the 3 ideas here, the incentive-based design, moving to composite filling coverage on molars, and excluding preventive services from counting against the plan maximum coverage, all of those, each of them individually, is a proposal that would cost somewhere between $1.25 to $2.25, and they're all kind of closely lumped together within that range. The question that came up last meeting was just kind of narrowing in on one of these 3, but it illustrates a broader point. The question was about annual plan maximum, and what would it look like if the annual plan maximum was just raised from $1,750 a year to something higher, say $2,000 or $22,250, rather than the specific proposal that the agency described or Ellen described last meeting about precluding preventive services. In the moment I had described that, we did look at a variety of different options and put together kind of a cohesive package. I wanted to give a little bit more insight on that one in particular because it was asked. So we did cost out what it would look like to raise the annual plan maximum. And that raising of the plan maximum actually cost more from a PSPM perspective than the precluding preventive services. That cost of raising the plan maximum also became the single largest until you start looking at Crown's cost of an individual benefit design option. But more importantly, it also impacted fewer people. So we were looking at 2 different versions of annual plan maximum proposals to bring to the board. And there was one that cost less and impacted, where it's estimated to impact 80% of the population, versus a proposal that cost more and impacted less than 4% of the population. And so as we're looking at broader equity concerns, broader access to preventive services, broader trying to normalize how preventive services are treated in dental versus medical, our proposal to you was to go with the conveniently lower cost, but broader impact to the population rather than the other benefit design option. So yes, in reality, there are many different, very specific proposals that could be designed. You could have dozens of different ways to design an incentive plan. There's not so many, you either cover the molars or you don't. So that was probably more of a yes-no situation. But each of these proposals could generally have a couple of different iterations, and we were trying to hone in on an overall package that would balance the breadth of individuals in the population that could be impacted, while trying to be cognizant of price costs to the entire package and what that would look like from our experiences at AGS to things that may be tolerated as an incremental increase in benefits during the biennial budget analysis process. So I did just want to come back and say, yes, we had absolutely looked at and considered bringing to the board something around annual plan maximum that was different than preclude preventive services. But the specific proposal that just happened to also be brought up in public comment was more expensive and impacted fewer people. So we went with bringing you a proposal around annual plan maximum preventing preventive services. So just wanted to provide a little bit of context of that from the public comment question that came up at the end of last month's meeting.
Thank you, Dave. So as a reminder, for the state and SEB organizations from a budget funding perspective, any one of these changes would impact the funding rate of these three changes. So an incentive plan or composite fillings or changing the annual plan to exclude preventive services. So it's important to keep in mind the total expense of each one of these individually. Next slide, please. On TMJ and the child deductible, the impact of these two together is under 50 cents PSPM for the SEB program and under 25 cents PSPM for the PEB program. So again, from the state and SEB organizations viewpoint, these two changes combined are unlikely to impact the funding rate. And that's why we're considering them together. Next slide, please. If all 5 benefit proposals were put forward, the total cost estimate is $5 to $7 for each program, so for both PEB and SEB. And the estimated cost to the state to implement would be $15 to $21 million. And then the additional PSPM increase that we discussed in crowns is noted on slide 7. Next slide, please. Just some other factors to consider as you think about funding. These estimates are based on 2021 pandemic period utilization. Actual premium increases may vary slightly depending on utilization, and as a self-insured plan, ultimately the state has liability for all of the claims. Next slide, please. You've seen this slide before. As we talked about prioritization, we rank these in terms of the total impact on the population. So that puts the excluding preventive visits from the annual plan maximum at the top. And then cover composite filling, same as amalgam, would have the next largest impact. I do want to note here that King County recently made a change for county employees, and they have moved to covering composite fillings the same as amalgam fillings for posterior teeth as well, beginning January 1, 2022. The incentive plan is the next, and again, that's the number of people who had class 2 or class 3 services, but did not have class 1 services. Children's deductible, the number reflects the children under 15. And the order of these things for PEB would be the same as the order for SEB because the population impacts are relatively the same percentage-wise. Was there a question?
Yes, Pete.
Yeah, Alan, this Pete here. The numbers showing the impact for the excluding preventive visits from the annual plan maximum, would that be the number of persons that have annual plan, preventive visits in a year, or because I have a hard time believing that many have the visits plus also hit their annual maximum?
No, so it's just the number, the 208,000 is 81% of people had planned maximum visit, had preventive visits.
Okay.
So the impact would be, this would allow, if we made the change, it would allow more plan coverage for other services.
Right, but we don't have that many people that are hitting the annual. Is it
No,
true to say that there aren't that many that are currently hitting the annual maximum?
The annual plan maximum has only been reached by about 4% of members.
Great.
In total.
Okay. Thank you very much.
We have an additional around 8 to 10% that are within $250 of the plan maximum. And so one of the things that I think in the prior meeting slides was kind of examples of how sometimes members are in situations where they blow through their plan maximum at the beginning of the year, and then they may avoid preventive services in the second half of the year because they doubled up or they went in to get, a root canal or something earlier in the year. So it's just kind of, yes, there's a strict kind of 3-4% of the population that will have literally been hitting the maximum, but there's another 8 to 10% that have been with assuming that they might have more out of pocket if they reach their deductible with the service that they're avoiding at the moment until the plan accumulator reboots the next January. So we kind of look at it. We also looked at that next set of individuals who are close to but have not yet been hitting the maximum.
David, and I can speak from personal experience that your observation is absolutely spot on. I have hit the maximum at least 1 year, and I have other times have juggled the timing of preventative care in order to try and avoid going over it. So I think it's a great proposed change.
I see question for Donna, or I won't assume questions. Donna?
It's very similar to the question he just had, and your answers were great. It's just that number looks very deceiving then to me, that 81% would benefit from it, when in reality it may be lower than eliminating the children's deductible. Does that make sense? That the number of people that would actually benefit from excluding it is probably significantly less.
Yeah, I guess I definitely understand that. I guess there's a way to think about it as like individuals who might directly and more immediately see a change in either their behavior or actual out-of-pocket expenses. The other piece that we thought about, though, is there are individuals who may incorrectly assume the cost of preventive services and maybe I think there's a piece of this that's kind of a marketing that goes, all preventive services, just like medical, has nothing to do with anything with your deductible, whereas some people we perceive believe that they may have more costs, that they don't understand the cost relativity of the preventive services with the actual amount of coverage. So there's still the perception of the plan's coverage and its relationship to preventive services that can be decoupled with this proposal. But from a strict sense of individuals who may have money coming out of their pocket that won't see that same money coming out of their pocket, it could be somewhere more in that 15% range of individuals who are within $250 or reaching the annual plan maximum in recent years. So yeah, just wanted to add that context. We were thinking about how the perception of the benefit also drives utilization to some extent, but from a dollars out of your pocket standpoint, it's not 80% of people who are suddenly going to have more money in their pocket.
Thank you.
I also wanted to point out that in the appendix, there's some more detailed information on utilization across the SEB program for the different classes of services. Next slide, please. Go back, please. Thank you. When we looked at the different options and the estimated premium impact from lowest to highest, it changes the order of the different options. And there's a difference between the PEB program and the SEB program on the third line, which is based, third and fourth lines, which is based on utilization within those programs. As mentioned earlier, crowns have an additional impact beyond what is shown here. And if they were to be fit in, depending on their coverage level, they would be at the lowest point because they have the highest cost impact. Next slide, please.
Ellen, real quick, I was just reflecting a little bit more about Donna's question/statement. I wanted to add one more piece to it. Donna, the other thing that I was thinking about that we've had conversations here as to why we included everybody who has a preventive services in that 80% number is when you have a preventive service, you get an explanation of benefits, and it shows the tracking towards reaching that annual plan maximum. So every time you go in for services, you get a new EOB. It shows the first time that $125 was eaten up. The next time you're now at $250 or $275. If you're on periodontal maintenance, you start seeing that creep up into that $600-700 range just for your preventive services. And that starts with getting us into the same mindset with Pete's question of people who start to try to look at what they anticipate. You know, if I'm spending $500-600 just on preventive services, and then my dentist tells me I'm going to have 2 crowns, I can go through and get a predetermination of benefits. It's not a guarantee of coverage, and we've all heard that line before, but you start to get that dynamic of having to weigh those choices about what you're going to get care for. And this proposal just eliminates the entire process of seeing that accumulator start to build up as you're going for preventive services. And so our idea was that would impact potentially how someone is interacting with more extensive services. So just that was some of the kind of the behavioral economics of getting an EOB, and everybody who gets those EOBs and sees part of their benefit eaten into simply for getting a cleaning. That was a little bit more as to kind of the reasoning. I had forgot to say the EOB part, really wanted to come back and just draw attention to that and that behavioral experience that was part of our conversation as we talk about whether to include everybody or not. And that's the impact we were thinking about.
Thanks, Dave. So I wanted to share some feedback from the April SEBB board meeting. There was consensus that preventive services should be emphasized. And I'd like to make a note here that the idea of excluding preventive services from the annual plan maximum is an innovative idea. It's not currently being done by the largest employer groups within Delta, which includes Amazon, Boeing, T-Mobile, Alaska Air, for example. It's more common in their small and mid-sized market plans, and it's called a diagnostic and preventive waiver. And that's generally much more common than incentive plans, and almost never are the two combined. So I just wanted to make a note about that. The other feedback was skepticism about the incentive plan design. There was real concern that there shouldn't be any judgment for doing or not doing preventive services, because there are so many different factors that come into play. And there was concern about a return on investment for employers who are paying for the benefits, and a concern that the incentive plan may not actually drive the expected behavioral changes that we would like to see. And on the idea of not penalizing people in these times of high inflation, people have to make choices between other non-dental expensive services and goods. And so it seemed there was a lot of concern about making a behavioral impact based on having preventive services or not having preventive services.
I just want to be clear that Ellen is describing the feedback that came from board members. I just want to be very clear that this is a summation of feedback. There's a few more slides with additional discussion, but I want to say that. I see, Pam, you have a question or comment?
Yes, I'm trying to wrap my head around the, maybe you can go more into this, the fear or the not understanding how an incentive plan would work. Could you go deeper into that for us? Or at least from the PEB point of view, like what was being said that they weren't understanding it, I guess is my question.
I'm not sure that they didn't understand it. But there was concern that if we went to an incentive plan at that cost, that there were a lot of reasons for not getting the preventive services. So that would lead to a lower coverage in the following year. So there was concern about inequity and how the plan would actually carry out.
Okay.
Does that address it?
It helps, and I guess in terms of comment, sometimes there's fear of the unknown, and I'm approaching it from, I always had it growing up, so I knew what it entailed. So I guess maybe further education or further discussion might be in order, because I can tell you that WA members are very, very interested in an incentive plan. So maybe further discussion would be helpful.
And I
Pam,
think that
I would say that there were a couple of board members who said they weren't necessarily against the idea of kind of forever, but they also seem to prioritize other parts of the proposals above it and said maybe there is more that can come at a future time. There was definitely some more information might be worth it, but even with what they had, they felt that there were other things that could be prioritized. The other kind of piece that fits with this first sub-bullet was the idea that the employer is paying 100% of the premium, and preventive and class 1 services under the current plan and the incentive plan design are still 100% services. So what is there really going to be a motivation when there's nothing changing about those core aspects of the existing and future state incentive design to really drive behavior change? When that was kind of, that's when Ellen said there was some comments on return of investment. It was kind of in that realm of what more can you truly do to get somebody get a preventive service when the things that exist today should already be incentivizing it. This was kind of a theme that came up. And Ellen, always keep me honest. I think I'm trying very hard to make sure that I'm describing what I've heard.
absolutely, yes.
Appreciate that extra explanation. Thank you.
And Pam, I was just going to say that I do think that it's a very valid observation that there's a difference between the PEB population and the SEB population in terms of familiarity with an incentive plan and how it works.
Right. Thank you.
Next slide.
Donna?
Sorry.
Yeah, I see Donna.
Actually, Ellen just absolutely said exactly what I was going to say about the difference between the SEB and the PEB people, and the fact that that was our incentive to make sure that we always got our preventative care done so that we continued to get that discount. So definitely two different populations.
Now you can go to the next slide, Ellen, I think.
Okay, thank you. So again, there was general support for the child-focused aspects of the proposals, but there was some concern about segmenting the population. And obviously on the PEB board, there was concern about a limited impact with retirees having to pay the increase fully because, as you know, retirees are on self-pay and don't have coverage for dental without them paying for it. There was a question on composites used for posterior baby teeth, and we clarified that yes, it happens, but it's there has to be a medically necessary reason for using a crown on baby teeth, and medically necessary is the standard for all crowns. So the dentist has to justify that a crown is needed, but composites can be used for posterior baby teeth. And there was a request that eventually we compare projections with actual utilization, because as we all know, the ramifications of the pandemic years are not truly over yet. And so we don't know what's going to happen in the future. Next slide, please. So as we ask you to sort of, this is the last chance to consider these things. Are we focusing on with the correct lens by focusing on population impact? And is there anything that you think that should be dropped or anything that should be ranked higher, and why? And I just want to say, next slide, please. We're taking into account, the board consensus on the recommendations. We're also gathering other stakeholder input, including labor organizations, and HCA will be putting together a decision package for submission this fall. And a reminder that Tanya Jewell will go over decision packages that are included in the governor's budget when the board meets for the January retreat next year. So with that, let's go back to the discussion slide.
I am hoping that we have some robust discussion today, and whatever is discussed today, we will describe to the PEB board at their meeting next week, just like we just described the PEB board's discussion that happened last month to you. So very much hoping to be able to share and kind of cross-pollinate some of the thoughts from the different perspectives. So great, Donna, your hand shot up, so please proceed.
Yeah, I do not want to open a can of worms, but I do have a question based on something that a couple of employees have asked me about, and it's the non-duplication of benefits clause in our insurance, our dental insurance. Is that standard procedure across all of, the market, or is that something unique to Delta? I don't want to throw another thing out there that we could be looking at, but we do have a non-duplication of benefits clause. Is that standard across most benefits? If you have to do research on that, that's fine.
So I will have to do research on it. I know that it's a change from how WEA pre-SEB worked, because that contract did allow for duplication of benefits. But it has been a standard provision in the state contracts for a long time to have non-duplication of benefits, but I will research that further.
Thank you.
Expect some follow-up about kind of market analysis, if you will, the market comparison piece that we've been trying to do throughout this discussion, so we can have that as follow-up. So at this point, I know Ellen said she said the word last chance, which, the context of the benefit conversation continues on forever, until 2024 or 2025 or at any point. But what she really meant was we're about to really get into writing the decision package. And once those motions really start, the decision package process starts to take on a bit more of a life of its own. So this is the best chance to provide some insight that can help shape that decision package. And we do intend to describe what we hear as some of the insights from the board in kind of a narrative portion of the decision package. And Dan raised his hand, so I'm going to be quiet. Dan.
This has kind of already been kind of said, but if one of the things I would like would be to encourage preventive services, the incentive plan that we are used to as SEB employees, it did that because we always were trying to get up to 100% for class 2. And so it was an added incentive to go in and get those preventative services, even though they were already covered at 100%. So we went in every year. We're used to that. I know the PEB population isn't. And that's, it's a real conundrum, I guess. I don't know what else to say. Thank you.
Carrie?
Yeah, just to piggyback on what Dan said, I have to agree with him. Dan was there at the beginning of all this too, when we began this whole discussion, and we knew we were going to be losing dental and vision benefits in the beginning, with hopes of when we have this discussion in the future that we would be able to get back to where we were or close to it. And I just feel like we've lost a lot in that foothold there, and we need to kind of get some of that back. So I would still like to look at ways that we can do that for our members.
I'm gonna have some questions for folks. I want to keep you that. Donna raised her hand, and so Donna.
I absolutely agree with Terry as well. Preventative drives down the cost of those class 2 and class 3 things. You go in for your checkups, and we're used to that, and it's something that our members are asking for, and they want it back. So it would be nice.
Ellen, do you have any insights to share about the impact on claims and utilization of class 2 services based on individuals who get class 1 services? I'm thinking we did do some analysis on that, but I'm not as confident as I asked you that question. So is there anything you can share about that?
Unfortunately, I did receive some research on that, but I haven't committed it to memory, so I can't answer that offhand. But certainly we can provide follow-up on that.
Let's at least plan on that. Pete.
Yeah, I just say, having had prior experience with the PEB world for quite a while, my off the cuff reactions, I don't think there's any significant difference in the nature of the two populations that would result in the PEB members not appreciating and taking advantage of the incentive, and to a level that corresponds roughly to what the school employee experience had been with the WA plans. As always, with everything we're discussing here, there's a question of additional costs, and we have a uniquely, I don't know what adjective to use, but I say complex situation where we're discussing benefit design and benefit design change options that would impact state spending, but at the same time, decisions about what the funding level for these benefits will be is conducted through an entirely different process, entirely different group, well, a different group. And I'm sure the decisions about, or the positions about what would be endorsed would probably vary depending on how much money is available to pay for these without having to raise employee premiums. So, and I don't know how to weigh that into our decision making. But for the record, I do think that the incentive plan, if it worked well with school employees, I'd be, from an employee benefit policy point of view, I don't see why it wouldn't also likely work well with state employee or PEB population.
The one maybe footnote refinement to your comments that I might suggest is the premium for dental in both programs is fully employer paid. So there is no impact to, you said employee premium, you might have meant employer, but I wanted to remind everybody that dental premiums are fully paid for by the employer. The one place where there is a direct impact on someone's pocketbook besides the employer is the retiree setting, as they self-pay the dental premium. So there's a direct out-of-pocket monthly impact in that self-pay retiree setting, but not for employees where the 100% of the premium is paid by the state or by the employer. Sorry, by the employer.
Well taken, good point, David. I guess I was kind of falling back into my old budget mental framework where I'm thinking that, well, if the state employer cost for dental goes up and you're in collective bargaining, then the amount the state or the employer is willing to put in for the medical benefits, which do involve an employee premium, that would go down. But I did not state that explicitly. So I agree. Your point is well taken. That if the connection between how much it goes in for funding of medical benefits is completely severed from what the state pays for the dental benefits, then it's just a question of what amount of dollars is the state willing to put in for the dental.
So I guess I'm curious, how board members are feeling about, kind of as Pete said in the grand question, at this point, I've not heard from both boards something that suggests fully eliminating one of the 5 proposals from the decision package. So if we're in a situation where we're describing all aspects of it and the total cost is that 5 to 7 range, which is, 15 to 21 million dollars between both programs, or for an implementation of all of this and all of that in both programs, and either the governor's office or the legislature saying no, not 5 to 7. Instead, we're willing to do something smaller than 5 to 7. Where would the prioritization fall if everything can't be had? Pam?
So this is where bargaining comes in. If you're going to make me pick, prioritization goes on 100% coverage and a dramatic increase in crowns.
Say that last part, Pam. It didn't quite come across here.
Sorry, I'm at school still. An increase in coverage for crowns. So 100% and then an increase in crowns. That would be my priority.
Just to be clear, I want to make sure I understand. You would prioritize a change in crown coverage versus everything else that's been discussed.
No, I'm tied right now. So the 100% plus the crowns, those are my top 2. And the rest I can argue later. I want to hear from everyone else.
Pam, can I ask a clarifying question?
Sure.
What do you mean by 100% coverage?
The incentive plan. So you
So
get
currently
70.
the incentive plan only goes up to 90% coverage for class 2. It does not go up to 100%.
Yeah, you asked me where my priorities are. I'm going to go for it.
Okay.
Yeah.
I just wanted to
And
clarify.
I have to advocate for our members because they have said over and over, and they send us with this direction that we want it back. And I mean, yeah, the proposal of going up to 90%, that's better, but we are going to continue asking. But if we cannot get 100%, we at least get an increase in that incentive plan, and then also coverage for crowns.
Great, thanks.
You're welcome.
As I watch from our hands, I do want to remind the board about one other difference in the incentive plan design that's proposed, because it does keep getting not mentioned. The class 1 benefit is richer today, and it's richer under the incentive plan. The pre-SEB school employees experience a sliding scale of 70 to 100% on class 1 services in the incentive plan design. They were penalized for not getting services by having lower cost shares down to the floor of 70% in future years. Under the proposal that has been described here, it's always 100% covered services. There's no sliding scale. So that is a richer comparison. You are not penalized. You do not start at 70% on your first year. You do not backslide down if you do not get preventive services. It is always 100% services covered for preventive services, regardless of whether it's a preferred or premier provider. So that distinction is also gone. So I do want to remind, because that does seem to get lost in the conversation. I do hear the difference about a 90% sliding scale on class 2 and crowns not being there, but I feel it's important to remind people that there is a richer aspect to this incentive-based design when it comes to the class 1 portion of it. So I do feel a need to highlight that piece, because it's both richer and less rich to what school employees experienced before SEB. So it is different in that way. Curious about how others would prioritize if the funding that was the investment in funding that would be brought by the legislature or the governor's office was not for a full proposal. What would be the things that you would most want to see funded? Donna?
I thought there would be
Like you
more.
were-
I thought there would be more people wanting to discuss this. This is surprising me. I agree that it is, to me, the incentive plan and the crowns would probably be my top two as well.
Okay. No, this board's usually not too quiet. Dan?
I will echo those same two in that order. That's what I've heard over and over and over again from members.
And Terry?
I will agree with the group, the incentive plan and crowns, that order.
Allison?
This feels complicated, and I am a little removed from the beneficiaries in this way. So I appreciate the comments of folks who are having daily conversations with school employees. And so I'm not sure I have a great sense of the ranking part. I just think it's really important that we recognize the fiscal limitations that are likely to be part of a legislative discussion like this. And that while we have sort of enjoyed some great economic expansion, it feels smart to be thinking fiscally smart about this as well, so we're not in a position of adding benefits or taking benefits back and so forth. So I think I would just add that into the conversation as we think about prioritizing.
So I'm curious, Allison, maybe from your experience with Medicaid, if there's any of these proposals that speak to you thinking about, I know that you have maybe an important perspective on equity lenses, and if there's anything that from your experience in that world that might be an interesting perspective for the conversation.
Yeah, for sure. Well, I think one, we saw just a tremendous impact when adult Medicaid dental had to be removed as a benefit here in the state, and then what that did to the network adequacy as we've been able to add that back in. I think a lot of care that many of us who sit in that middle class socioeconomic sort of take for granted is not always easily accessible. And so things like fillings feel super important to me overall, in ensuring that type of coverage.
Yeah, that is a really important perspective to bring about. The legislature could very well be debating, what to do with the extent of having adult dental in the Medicaid population, while we're putting forward a decision package about increasing dental benefits. And the entire concept could just fall flat, because if the conversation is about, this agency has had requests for dental provider rate increases on the Medicaid population, and there was a substantial investment made by the legislature just this last session for the first time in years. But we have been in situations where the legislature has saved child dental in the Medicaid program, as dental and Medicaid is not an entitlement the same way that medical is, protected children's dental, and we've had an ebb and flow of adult dental coverage. So the dental conversation in our state really does have a lot of facets to it, and there's this juxtaposition of Medicaid coverage in dental versus, an employer compensation program of the PEPID sub-program. So it is an interesting perspective.
Yeah, I really, and I feel a little wet blankety here, but I just feel like the word on the street is they're going to have some tough economic choices to make in the coming, both this biennium and the next biennium, and to really protect the volatility that I think sometimes plays out in healthcare as a way to sort of balance the overall budget. You know, the things that we can ensure exist feels really important.
So with Allison's reminder as a wet blanket that that there's tough budget decisions, the prioritization all the more important. I'm hearing the theme from Donna, Terry, Pam, Dan about first choice would be something incentive-based design, then additional crown coverage of some support would be important. A little bit of support for the amalgam filling piece from Allison. Want to open it up for any other comments or discussion from anyone? Amy?
Was that me?
Uh,
Oh, no.
Good afternoon. Sorry about that. I would have to agree with the incentive and crowns, and I apologize that my camera is off. I am in a conference at Spokane, WASBO, and we don't have the best internet right now. So, but mine would definitely be the incentive and crowns. We hear the incentive piece a lot from districts. I have to agree. Here at Olympia, our employees ask for that to come back quite often. So thank you.
Thank you, Amy. Pete?
Okay, I'm on. I just want to, I guess, join Allison's wet blanket feedback, but both of our points. I'm quite inclined to defer to the employee representatives regarding what would be a priority, what should be prioritized to the extent that additional dollars are, made available for improving dental benefits in the SEB program. The one policy bias I have, or public health bias, is that I would personally put a priority on the prioritizing of preventative services. And secondly, the question of what to ask for. I guess I'm not privy to what the state current budget issues are and challenges, but I guess it's just important to realize that we can ask for, $20 per subscriber per month be added to the funding. My guess is it's going to come down at some point to question of, okay, the state's not willing to add nearly that amount, and really what is the as David said, what are the top priorities? Because I will be very surprised if the budget process is welcoming a kind of give us your everything you would like approach. So anyway, in short, I'm endorsing in general Allison's approach.
Any other thoughts from anyone? We will take the discussion and share with the PEB board, similar as we did with this board today about the recent discussion at PEB. Go from there and appreciate. We'll have a little bit of follow-up for some of the questions that Ellen said she'd bring some things back, or we bring them back at the next board meeting. And I think then we would be ready for you have no more slides, right, Ellen?
No more slides. Thank you so much.
We're ready then. I think we're ready for the next discussion or next presentation.
All right. Thank you, Ellen. Thank you, board members. Good discussion. Next agenda item is vision benefit discussion. Beth Heston, Senior Account Manager in the Urban Division, is going to share results from the vision benefit survey completed earlier this year. Her materials are behind tab number 4. Welcome, Beth.
Good morning, Chair McDermott, members of the board. I'm Beth Heston. You've heard me speak before as one of the ERB procurement managers, but I'm here today as the SEBB Senior Account Manager for the vision contracts with Davis Vision, IMED, and MetLife Vision. Next slide. Let's talk first about the objectives for today's presentation. First of all, we want to share the results of our vision benefit member survey that Dave spoke to you about a moment ago. And then we want to discuss current coverage in the PEB and SEB programs. It's been about 15 years since the vision benefit was discussed by the PEB board. At that time, 2007-ish, we had implemented a yearly eye exam. Previously had been every 2 years. And we also introduced the $150 hardware allowance. And then, when staff was working with you to create the SEB board portfolio, our focus was on trying to reduce disruption to the SEB population. And most school districts had standalone vision carriers before SEB, so ERB procured to match that situation. The next item that we want to discuss is possible changes to the vision plans, and then to talk about how the decision package process affects any possible benefit changes. Next slide. So the ERB Vision Benefit Survey, it was a web-based survey that was conducted early this year, opened on January 26th and ran through February 11th. So why have a survey? Well, the reasons I mentioned above, the fact that PEB had a gap of several years since the last discussion about vision, and the decisions that we made when we built the SEB portfolio led us to want to know what people thought about the solution. And also, according to Vision Magazine Online, 75% of adults need some form of vision correction, but not all of them get it. Next slide. As we were planning the survey, we agreed that we wanted to ask the most important questions about our members' reaction and feeling for their benefits. But we knew that a survey that took the least amount of time for members to complete would be the most attractive. So we designed this survey very carefully, targeting the information we needed. Additionally, we wanted to be sure that we were getting what our members wanted to have changed about their existing benefit, not just our ideas for their experience. Many of us have our own anecdotal stories about our own experiences, but we wanted to know what others directly using the benefits felt about the coverage. We also wanted to get an idea about how much members were spending out of pocket. Real data, not just those, well, I spent this much last year. We wanted to see across the board what people were spending. And can you hear me?
You're back.
Okay.
You're back.
Where did I cut out?
About 30 seconds ago.
Okay. So I was explaining the reasons that we did the survey. We wanted to get something other than our own personal experience. So our goal was to get a broader look at what people are using, what's important to them, and concrete measurable information about what was most important in the benefit and how much people were spending. Next slide. All right, so we created, in order to achieve these goals, we brainstormed questions with a group of internal subject matter experts, and we had a lot of questions. So we worked to narrow that list down, because again, we wanted to make it as short as possible because that would attract more participants. It wouldn't take them long to complete. So we distilled that far longer list down, and I believe we selected the best questions to get a targeted response. We also called upon our folks in ERB Communications to help us build a communication plan. And we used outreach to benefit administrators and in all the various agency and school settings to send out emails and notices to get folks to participate. And when the data came in at the end of the allotted time for the survey, we used our internal data experts to help us analyze and quantify the answers to get the most accurate results. And you can see below that first bullet, the list of questions that we felt were most important. How are you eligible? So are you a member? Are you a dependent? What parts of the benefit do you currently use? How satisfied are you with the benefit? What's the most important portion of your benefit? Which benefit which benefit enhancements would be most important to you? And how much do you spend per year? Next slide. All right. In total, we got 22,000 responses. And that 13,000 of those were from PEB members, and 9,200 of those were from SEB members. And that matches pretty closely it's proportional with the differences in the populations. So this isn't weighted towards one program or the other. In PEB, that was about 3.5% of the population. In SEB, it was about 3.4% of the population. So the only probable bias in this number is obviously people who use the benefit are more likely to respond to a survey about it. All right, slide 7. This is the result of the question, which vision hardware do you use? And the survey I quoted earlier that said 75% of people need some eye correction says that 64% of those people wear glasses. And nationally, according to that survey, about 11% of people reported wearing contacts. But you'll see that our rate looks more like about 33.5% of the respondents wear contacts. And remember that folks could pick multiple choices on this one. So some of the people who are picking eyeglasses are also picking contact lenses and are also picking prescription sunglasses. That'll give you some idea about how that data is collected. Do I have any questions so far? Okay, next slide. This slide shows the result of the response to the true satisfaction question. The columns are divided according to which program the answers came from. And it is, at first glance, a little difficult to interpret. But if we think about the answer we want to see, obviously we want responses at least 6 or above. And so for PEB, at 6 or above, we had 43% of our responses. At 5, which is the neither satisfied nor very, neither very satisfied nor very dissatisfied, midpoint, we had 15% of our responses. And then the lower end of the scale, 4 and under, we had 37% of our respondents. For SEB, the numbers were sort of reduced or reversed. In SEB, we had 6 or above, we had almost 40%. Right at 5, we had 15%, just like PEB. But then 4 or under, we had 41% of our folks hitting there. So poorer marks for the SEB population. We did have some folks who didn't choose to answer. They said it wasn't an applicable question to them. So the numbers are not exact because about 800 to 900 people chose to say this didn't apply to them. Next slide. Now, I want to talk a little bit. This slide was ranking enhancements in order of preference from those most important to least. So again, we had quite a few answers all over the board because they were ranking them between 1 and 5, or excuse me, 1 and 6. So we took the top numbers of 1 and 2 rankings. But we want to talk a little bit about the terms of art in this slide. As you can see, we have progressive lenses, non-glare lenses, polycarbonate lenses, blue light filtering lenses, transition lenses, and tinted lenses. Those can be jumbled when we're dealing at our eye doctor's office with what we're having done. Progressive lenses are bifocals and trifocals. Whether they have lines or no lines, they're considered progressive lenses. Non-glare, pretty self-explanatory. Those are lenses that prevent glare in sunshine or when using them for reading. Polycarbonate lenses are, that question has to do with weight. Folks that have more complex prescriptions or stronger prescriptions often have heavy lenses. And so polycarbonate is a lighter material that you can make your lenses out of so that they will stay up on people's noses like mine, because frankly, I'm blind as a bat. All right, blue light filtering lenses are what we would call computer lenses, probably. They prevent eye strain from staring at a computer screen all day. And then we move to transition lenses. Transition lenses, some doctors mix the language on transition versus progressive, but in reality, transition lenses are the ones with the photovoltaic element to them that when you go out in sunshine, they automatically tint themselves so that you have working sunglasses inside and out. And lastly, tinted lenses are exactly what they say. Those are your prescription sunglasses. And you can see from our results that progressive lenses was the most important enhancement for our population. And given the average age of the population in both PEB and SEB, that's not surprising. I think PEB average age is 49, while the SEB average age is 46. So we're starting to look at those progressive lenses for our vision needs. And then the rest are ranked. The percentages are in the call out boxes. Any questions about that? Okay, next slide. All right, and this is the final question that we asked, and that was about the amount spent yearly out of pocket. So that's beyond what's covered by your hardware allowance. I do want to point out that because of the way the number was stated, there could be a number of people in that bottom category who spent nothing out of pocket. But we see that the weight is definitely on the lower two questions. How many spent 0 to 150 and how many spent 151 to 300. That's where the majority of our members tagged their out-of-pocket yearly expenses. Of course, we had a number who were above that, and those could be folks who are paying more for more complex prescriptions, prisms, the progressive lenses, the no-line progressive lenses are more expensive. But it could also have to do with the hardware that they chose, because some glasses frames are more expensive than others. And many people have a certain look that they're going for. All right. Are there any questions about the survey results?
Donna?
Is there any way to get data on that, on how they are spending it? Is there any actuarials that tell us anything like that?
We have not run that through our actuarial services, but that's certainly a question that we can research and bring back to you next time. This is, of course, our first meeting on this topic, and so we'd be happy to see what's available to us and bring it back.
Just to be talking about, like at slide 10, like what they're spending out of pocket on.
Yes. Yes. Are they getting designer frames or? Yeah.
Oh, okay. Yeah. Well, it'll be interesting to see what we could do about that, because this survey was about, in general, what do you spend, but if they're buying something that they never submit a claim on, that would show up here as this in this answer, because one might say, oh, I went out and bought X glasses and didn't even interact with my medical or standalone vision plan. I just paid out of pocket of it, and they could count that in here. We'd never have a claimable event. So we'll play around in that sandbox and see what we can come up with, but we would only be able to do anything that actually had a claim filed with it. So just wanted to draw that nuance and why I wanted to check in on exactly what you were asking. So we can't talk about what we don't know, but we can see what we do know, so to speak.
All right, Dave.
All right.
No other questions. Let's move on to the next slide. Now we're switching topics at this point, and we're going to talk for a moment about the current differences, mainly between the PEB and SEB programs. PEB has been an embedded benefit since its very inception, since 1977, when the PEB board was set up. It hasn't been changed much since the beginning, except in response to the medical plans changes in clinical criteria, occasions when we have increased coverages because of common practices, that sort of thing. The SEB benefit, as I said before, we were trying to reduce disruption to the SEB population, and so we went with the standalone plans from vision carriers. The other primary difference, obviously these are two different models, so they're going to create difference. The other difference is how they are administered. In PEB, vision is paid through the medical premium. And so the employee pays 15%, and the employer contribution, according to our established collective bargaining agreements, is 15%, and the employer pays 85%. On the SEB side, of course, the vision is paid 100% by the employer. Next slide.
That employer coverage and sub includes dependent coverage as a reminder too, similar to dental.
Yes. Yeah, SEB is also getting pay for all dependents. And the PEB is wrapped into the medical. So if someone they're dependent on medical, they also get the vision. Okay, the other main difference between the programs is that the PEB vision plans use the medical plan networks. So you go to your, if you're in a Kaiser plan, you go to a Kaiser provider. If you're in UMP, you choose a preferred provider that's in the UMP network. The SEB population uses networks that are established by the standalone carriers. And I believe that all of those are preferred provider organizations. So the network could be very different between a medical plan and a standalone vision. And some have coverage not just in state, some are crossing state lines, and many cross county lines within the state of Washington. So the one place where both programs align is in the benefit allowances. Both programs have annual eye exams. Both programs have frames and lenses or contact lenses covered every 2 years. And that 2 years resets on even years for SEB. We do not have that differentiation on PEB. You switch when your 24 months is up. And then the $150 in-network allowance for hardware is the same in both programs. Any questions on those? There are more detailed information that does sort of a deeper dive available in the appendix at the end of this presentation that compares, apples to apples across the two programs. All right, next slide. We have possible changes available to us, okay? The first change would be to embed both programs' vision benefits in the medical plans. Wrapping into medical would mean one-stop shopping for medical and vision. For those using a managed care organization, you would have same building for the fully insured plans. You wouldn't have to search for a provider, no need to select another vision carrier. So that would be a whole person care. Vision results available to all providers within the system if you're in a fully insured plan. So there are some positives to it. However, SEB is currently not using that model, so it would be a disruption to the SEB population. Our second possible change would be to offer both programs benefits through standalone vision plans. And obviously this would push the disruption onto the PEB population. But there are some benefits to doing that. If we chose to offer standalone vision plans, we could consider creating a self-insured uniform vision plan to offer alongside other standalone vision plans. That would put the state, or at least the ERB population, that would mean that that the state would be paying the whole cost, because it would be for SEB, it would already be employer paid. However, for PEB, the the cost of premium is calculated into the tier rated average on the 85-15 split. So that's one difference that could or might remain. This also would, because of the allowance to go outside of a medical network, this would offer some folks a way to use their benefit that makes the allowance offered go further. They could choose someone who's not in the medical network to be their eye care provider. Any questions about those options? Dave, is there anything I missed?
These are just grand differences between the programs that from an administrative complexity standpoint, maybe it would be ideal to have one way of doing things. It's just something for evaluation as kind of some of the more overt big differences between the programs. So just highlighting that some of the big questions. Pam?
Hi, Beth. You used the phrase, it would be a disruption of service if we moved vision into the medical plan. Could you elaborate on that? And then I have a follow-up.
Yes, it would. Yeah, it means that if we wrapped the SEB vision benefit into the medical plans, everyone would have to drop their coverage and consider the vision coverage in their medical plan as part of their choice. They would no longer have a choice to make that I'm going to have Premera as my medical provider, but I'm going to choose MetLife as my vision provider. Instead, they would be choosing Premera, and that would include their vision. And,
okay, that makes more sense. Okay.
Okay, and for PEB, it would. Sorry, Dave.
I would say the disruption is really about whether you're picking twice or picking one thing.
Yes.
Right.
It's embedded. You know, PEB members have experienced for years that they pick their medical plan and it comes with the following vision coverage within it. And sub members and pre-sub experience, you pick your medical plan, you pick your hardware plan, two separate independent decisions. So in either direction, the disruption isn't, quote, a loss of coverage. It's really about how that coverage happens. So I just want to be really clear. It's not a loss or dropping of coverage. It's just, is it covered within your medical documentation or is it covered in a completely separate booklet?
That makes sense. Yeah.
And when staff talks about disruption, we want to know what's going to make people hurt. And so it's not going to hurt them that they're going to lose their coverage, but we do get a lot of complaints when people have to change the way they're doing things, and that makes them uncomfortable.
We are creatures of habit. We don't like change. No. Thank you for that clarification.
Sure. Other questions?
Hi, Beth. I would say if we had the SEB program switch over to the PEB model of getting your health benefit, your dental, one more time, vision benefits through your health plan, that it might come as a particular shock for those SEB members who get their coverage through Kaiser Permanente, because there, if I understand correctly, the $150 benefit towards hardware every 2 years can only be accessed if you purchase your eye hardware from Kaiser through their optical offices, which can be more expensive than other providers of those same equipment. So you could end up with somebody thinking, well, I'll just go with Kaiser, and then find out that, whoa, I effectively have much less vision coverage than I did before this change was made.
Yes, Pete, that being a Kaiser account manager, I understand that the Kaiser prices are set and are not perhaps as favorable as some of the other options.
Yeah, thanks.
Right. If there are no other questions, we'll go to the next slide. So today, this is the board timeline. And so today we are introducing this, this discussion to you with some of the points that we would like for you to think about and have presented and you've asked for more information about. Next month at the meeting, we're going to have data on utilization. We'll follow up on those questions you asked us. And we also should have some information on potential costs if we make the change. And then we're hoping to have a consensus discussion with you in July as we move forward. Next question, next slide, next question. Next slide. And so this is going to fall into the same decision package cycle that Ellen has been speaking to you about, and that control all of our benefit changes, that we need to write a budget decision package for the benefits during summer. And so we'll introduce that decision package. Then in December, we will learn which of the budget proposals were finalized by the governor in spring of 2023. Those will go, the biennial budget for fiscal year 2023 to 2025 will be finalized by the legislature. And we have put that a possible benefit change could be lined up for January of 2025. All right, next question or next slide. These are the questions. Are there changes not suggested here that you would like to see? Are there topics that you would like researched further that we didn't get to earlier in the presentation?
Let's say, as always, if there are things that come up between now and the next meeting, you can send Beth or I emails so that we can incorporate things as we prepare presentations for the next meeting. So I think that's always an option, and appreciate that. And I want to help us try to get back a little bit more on time. So, okay. Chairman Gray, I turn back to you for the next presentation.
Thank you, Beth. Appreciate it. Our next presentation is tax advantaged account procurement overview, and that's Kelsey. Is the pronunciation Pele?
Yeah, Pele. Yes, kind of like the soccer player. That's how I.
Awesome.
Yeah.
And she is a senior account manager in the ERB division, and she's going to present about our tax advantage benefits and an upcoming procurement related to those benefits. Kelsey's materials are behind tab number 5. Kelsey, welcome.
Thank you. All right. Good morning, Chair McDermott and members of the board. For the record, my name is Kelsey Pele, and I am a senior account manager in the portfolio management and monitoring section. Today, I'll be giving an overview of the tax advantage procurement process. Next slide, please. Our objectives today are to first start off by recapping about the benefits. Then we will discuss the recent refinements that have been made. Then we will address the scope of work changes that have happened over the past couple of years. And then lastly, we will walk through the FSA procurement details. And just to note, these benefits are all authorized by HCA's cafeteria plan. So this presentation is just informational and nothing in this update requires board action. Next slide, please. So SEB employees can set aside pre-tax money from their paychecks to pay for eligible medical expenses. We currently offer 3 tax advantage benefits. We have the medical flexible spending arrangement, the medical FSA, limited purpose FSA, and dependent care assistance program, DCAP. These benefits are all administered by Navia Benefit Solutions, which is located in Renton, Washington. And also our SEB members elect about $22 million out of their payroll deductions for these benefits each year. And as we know, these benefits have been extremely active and popular for our members to use. The medical FSA reimburses qualified out-of-pocket medical expenses, including annual deductibles, co-pays, co-insurances, and other eligible expenses. Members can also determine the annual contribution amount. They can choose to set aside a minimum amount of $120 up to an annual maximum contribution of $2,750 for the plan year 2022. The limited purpose FSA is a benefit intended for SEB members who are enrolled in a high deductible plan. This allows our members to save more of their HSA funds for medical expenses, since the limited purpose FSA can only be used for eligible dental and vision expenses. And then SEB members can also choose to enroll into a Dependent Care Assistance Program, DCAP, which operates the same as a medical FSA, but pays for eligible child care and elder care expenses. Next slide, please. So as we know, COVID-19 greatly impacted our healthcare system in 2020, which in turn impacted our members and their healthcare expenses as well. So the IRS and Congress created flexibility and opportunities for states to allow relief for their members. So HCA created a limited open enrollment period in July of 2020, where participants could prospectively adjust or end their contributions for the rest of the year up to the amount that they've already had spent. And then in 2021, we also allowed participants this opportunity to prospectively change their elections in both DCAP and FSA in 3 different times. So in the month of March, July, and September. And then the most recent refinement that has been made that went into effect in 2022 was the change to the FSA design. And so we lowered the minimum elections by 50% from a minimum of $240 to $120. We also transitioned from a grace period to a carryover design and added the limited purpose FSA benefit. Next slide, please. So over the past couple of years, the scope of work has expanded for our tax advantage benefits. We added school employees to the existing Navia contract, which bolstered up utilization of these benefits. And now for something kind of completely different, HCA also administers a healthcare program for the COFA, which stands for Compact of Free Association Pacific Islander Population. I want to call out here that SEB does not finance or subsidize this program. The COFA Islander population originates from the Republic of Marshall Islands, the Federated States of Micronesia, or the Republic of Palau, but currently resides in Washington State. In 2019, HCA began to use health benefit accounts, HBAs, which are initially access debit cards for Pacific Islanders who were not eligible for Apple Health. These debit cards pay the monthly premiums and out-of-pocket expenses for eligible COFA Islanders. Congress has since restored Medicaid eligibility to COFA Islanders, but we still need to keep the service for those who are ineligible for Medicaid. COFA is run strictly through Medicaid, and there's no real scope of impact here, but I do want to highlight that this was a great opportunity for the agency to find creative solutions to use our commercial contracts to address access problems and bring urban Medicaid together to serve all of our populations for the state. All right, next slide.
I just want to add one piece. That I'm realizing now, even though I've seen the slide deck so many times. When we're talking about scope of work, we're talking about the work that is contracted out under the single contract. And so right now, Kelsey's describing kind of the change in the type of work that is being done under the contract. And this is where we start to lean into, we need to do another procurement, because what happens is if an existing contract starts to get additional kind of scope creep from the original procurement, that's a signal to a state agency that they need to go out for a new competitive procurement. And so Kelsey right now is describing some of those things that have been added to this work stream, SEB being a very major component that was added to an existing contract. At the same time, this COFA Islander program has come up, but she's describing the types of things that weren't necessarily originally envisioned in the procurement that results in the existing contract. And as you're starting to gather, these substantial changes are what's prompting us to need to go out for procurement. So I just realized that the phrase scope of work probably doesn't mean much to people who aren't in the contracting world. So back to you, Kelsey.
Thanks, Dave. So next slide, this actually is a great segue into procurement. So given the significant changes and demands on the contract due to the expanded scope of work and experiencing a participation increase of 150% due to the onboarding of SEB and the $250 medical FSA contribution for represented PEB employees, we decided to procure early in 2020. However, we canceled the procurement after we could not reach an agreement with the apparently successful bidder, the ASB, during contract negotiations. And it was at this time, since we had 2 more years on the existing Navia contract, we used that as an opportunity to renegotiate the current Navia rate, which resulted in over $300,000 in savings for the last 2 years of the contract. Right. Next slide, please. So the 2020 procurement process taught us many things for future procurements. First, in order to attract bidders who can manage the number of accounts we maintain, we learned we needed to set minimums for the number of accounts the bidders manage both in their book of business and for their largest client. Second, we realized we needed to change how we present the possibility that ERB's HSA business could be added to the contract in the future. A little more background about HSAs. So Healthcare Authority, HCA, has about 20,000 plus HSA accounts maintained for high deductible plan subscribers. And they're currently managed by Health Equity, which is under contract not with HCA, but with our health carriers who offer high deductible plans. So with the idea of bringing HSA business in-house in the future, we are including that possibility in the RFP, but also ensuring that bidders base their administrative and cost proposals on the FSA business we're procuring for, not just the HSA business that could come along later. And then third, we divided the bid review process into 2 different phases. First, we'll review the bidder's security and technical proposals to ensure that they can do the work and protect our members' health information. And once we know they can do that, then we will review the rest of their proposals. If they don't pass that first technical security part, they'll be done. And this is just to ensure the reviewer's time is not wasted as well. Next slide, please. So in our 2022 procurement, we are currently drafting the request for proposal. And here is a list of the services that are included. We have the medical FSA, limited purpose FSA, the $250 CBA contribution for represented PEB employees, dependent care assistant program, health benefit accounts for COFA, and future HSA business. And then next slide, please. I would also like to call out some important procurement dates we have tentatively scheduled. Like I mentioned before, we are currently drafting the request for proposal, the RFP, and then we plan to issue the RFP out in late May after we announce the ASB, apparent successful bidder. We will go through contract negotiations and implementation. And then the new contract plans to go into effect on January 1st, 2024. Next slide, please. This concludes my presentation. I want to thank you for listening. And if you have any questions, please feel free to ask now, or if anything later on, don't hesitate to contact me, Dave, or Connie.
Hey, Pete, I see your hand up.
Yeah. Hi, Kelsey.
Hi.
Hi. Do I infer accurately that the intent is to have a new contract that, in addition to the different services or functions that are carried out for SEB and PEB members, that it will also continue to include what the program that provides the benefit to the COFA Islander individuals? Is it?
Yeah, that is correct. Mm-hmm.
I just have to say, as a SEB member, SEB board member, I find that really well, puzzling and maybe concerning. It just in my mind, the healthcare authority, has quite a bit of program activity for healthcare services and programs provided to low-income individuals, most associated with Apple Health. And at this point, it sounds like we begin to start blurring the distinction between those kind of programs and the SEB/PEB programs. I don't know that it's really a problem, but just my instincts are that it would be better for, at least in terms of maintaining clarity of roles, if they were not merged under one contract. But that's just an initial reaction.
I do just want to reassure you and the board that we negotiate separate rates for that program. So there is absolutely no subsidization. It's just a different paragraph or page in the contract that the agency, as we had the ability to have a vendor that can review qualified expenses in a debit card program, it became a natural opportunity to increase access to care for those individuals in that program. So we've leveraged the contract. In some ways, one could argue that, adding the SEB program could be a completely separate contract. So I just want to reassure, importantly, that there's no subsidization. It's just actually, trying to efficiently use our contract processing, and it's a separate rate within this contract. It's just a separate part that is just kind of on the side, and there's absolutely no cross subsidization of any kind between the PEB and SEB programs and that service that is also now historically part of this contract.
David, that's helpful. I mean, because I think the cross subsidization, especially if it's not being, if the financing is not being looked at really carefully and transparently, could be an issue. But so that does go up probably to my main concern, but it still seems strange. Thanks.
I knew that was your biggest concern, so I wanted to make sure that was clear.
Other questions or concerns? All right, seeing none. Thank you, Kelsey. Appreciate your time.
Thank you.
Next up, we have a Smart Health update. Kristen Stomanoff, the Washington Wellness Program Manager, and Jenny Switzer, Senior Account Manager in HERB, going to bring the board up to date on Smart Health and upcoming wellness procurement. The materials are behind tab number 6. Welcome.
Thank you. Good morning, Chair McDermott and members of the SEB Board. My name is Kristen Stomanoff, and I'm the manager of the Washington Wellness Program. Today, I'm going to briefly share with you information about our recent upgrade to the new Smart Health platform, and then Jenny Switzer will give you an overview of the upcoming wellness procurement. Next slide. On April 12th, Limeade, the Smart Health vendor, officially moved us from their Limeade Classic platform to the upgraded Limeade One platform. We now have the critical security enhancement of multi-factor authentication, and this requires users to provide 2 or more pieces of evidence to verify their identity and get access to an app or a digital resource like Smart Health. With the new Smart Health resource, people, of course, still have access to activities to improve their well-being. And there are also new features like updates, where you'll see time-sensitive announcements and other information. And there's a section that houses information about benefits and resources, so people can access a lot more on the new experience. For people who like to use Smart Health on a mobile device, the look and experience on the app are now almost identical to the desktop version, which is different than in the Limeade Classic platform. Next slide. To make sure that members had adequate information about this upgrade experience, because it is a change, HCA and Limeade launched multiple communications before the upgrade, during the upgrade, and after. So I want to walk you through some of those. Before the launch, all registered Smart Health users got an email from Limeade giving them a heads up about what was coming and how to prepare for it. And that was in late March. Our Washington Wellness Program team also created a toolkit. We call it a toolkit for wellness coordinators because it has different pieces that they can use to provide information to the staff that they support. So these toolkits included a forwardable message that wellness coordinators or benefit administrators could send to their employees. It also included an article that they could use in their agency newsletters and a flyer, and you can see that flyer pictured on this slide. On launch day, which was April 12th, all Smart Health users got an email from Limeade, and all SEB and PEB members who have signed up for emails through Gov Delivery from the Healthcare Authority got an email from the Healthcare Authority. And we also sent our wellness coordinators and benefit administrators another message that they could forward to employees. Then shortly after launch, within a day or two after that April 12th launch, there were posts on the Healthcare Authority's social media pages, on our Facebook page, on our Instagram page, on our LinkedIn account. So there were notices there. And then 2 weeks after launch, all of the registered Smart Health users got another email. So we hope that this wealth of communications has really helped people understand the change and be ready for it. I asked Limeade for the most current numbers. As of yesterday, we've had about 9,100 people sign in on the Limeade One platform, and that includes about 1,800 SEB members. And we're certainly hoping to drive that number higher and higher every week. Next slide, please. So in January, Smart Health restarted, as it does every year, with people's points resetting to 0, activities being reset, and any incentives that people qualified for in the previous year being applied to their deductibles or deposited into their health savings account. But we really treated this January reset as a soft opening because we knew that we were waiting for the cutover to the new Limeade One platform and that we were going to really want to get a lot of people engaged once that happened. So like I said earlier, the cutover actually occurred on April 12th. It did require about a week of downtime during which Smart Health wasn't available to members. And this was communicated in advance via email. And there was also a message on the site in case someone tried to log in during that period, telling them to check back on April 12th. Now that we're up on the upgraded platform, we're ramping up communications and promotions to get people engaged here. I showed you on that last slide the communications that happened before, during, and after the launch. And now, to really drive excitement and engagement in the new Smart Health, Limeade is going to be offering us some new promotional opportunities. So the first is a pair of tickets to see the Seattle Storm women's basketball team this summer. And Smart Health users will have a chance to be entered into a drawing to win these tickets. Limeade is providing these tickets at no cost to the state of Washington. We wanted to be sure to let you know about that. And they are also looking at additional sports ticket promotions for games and sports later in the year. And we're also, sorry, go ahead.
We might encourage the individual to stay till the end of the game. That's a little
right.
Little smart health inside joke. We had playoff tickets for the Seahawks, and the individual left the game, and it was a miraculous comeback in the Seahawks.
Oh my goodness.
People to stay there throughout the whole game. We always have a chance.
We'll have to include that in the promotions and in the smart health activities. That was before my time, so thanks for that information, Lou. So we will definitely be keeping you posted about additional promotions that will be coming. We'll have more information about those soon. And we also wanted to let you know that we're thinking about different types of promotions that might incentivize people who aren't necessarily excited about sporting events. So as new opportunities come up, we will be very pleased to share them with this board. But at this stage, I'll turn it over to Jenny to talk about the new wellness procurement, and then we'll both be happy to take questions at the end.
All right, thanks, Kristen. So good morning, Chair McDermott and members of the board. My name is Jenny Switzer, and I'm a senior account manager for the Uniform Medical Plan and the contract manager for the state virtual wellness contract. I'll be providing information today on current and upcoming work that HCA is doing for wellness procurement. In prior board meetings, Tanya Duell highlighted a decision package that was submitted for upcoming procurements. This is an example of one of the procurements included in that approved decision package. No actions necessary from the board, but we felt it was important to keep you informed on the procurement activities that will be taking place. So to provide a little bit of background for those of us that may not be aware, in October of 2013, the governor signed Executive Order 1306, which included a requirement that a state and employee health and wellness steering committee be convened to work towards implementation of a health and wellness change for state employees. This committee was to be co-chaired by HCA and the Department of Health, and they were tasked with developing a comprehensive wellness program that included incentives for state employees. The basis for the need of a state wellness program is that when employees are offered educational tools to manage their wellness, HCA and SEB organizations can promote a healthier, more productive work environment. Additionally, research indicates that a wellness program can support reductions in healthcare costs, improve productivity, and increase employee retention. As a result of the work done by the Health and Wellness Committee, HCA initiated a competitive procurement to select a vendor that would meet the requirements of the executive order by offering a comprehensive wellness program that focused on physical, emotional, relational, and financial health, along with improving work-life balance. Limeade was selected as the successful bidder, and that's what Kristen was just talking about for that procurement. And HCA entered into a contract with them that could last up to 10 years. With the end of this contract nearing, HCA has begun the process to identify requirements to procure a virtual wellness vendor to meet the needs of our members. So on the next slide, we'll go over some procurement goals. To ensure we select a vendor that provides value and necessary wellness requirements to improve health and well-being, we developed high-level goals that are expected of a successful bidder. Obviously, we have more drilled down specific technical and programmatic goals than what you're seeing here, but at a high level, we want to ensure the vendor and their product offering is a holistic program that supports employees in their physical, emotional, relational, and financial health and well-being, and promoting healthy work-life balance, like I spoke of before. The portal must encourage participants to complete a well-being assessment, also known as a health risk assessment. This information can be used to develop custom content to support the employee in making health and well-being progress in areas that they indicate are areas of improvement. The activities, challenges, and resources within the offering must be targetable so that members can receive impactful information that's appropriate to each individual. This includes ensuring employees have access to resources available to them based on health plan, their organization, and member self-reported information through the well-being assessment that's used to customize that experience. And finally, the portal must meet the Office of Cybersecurity requirements for data security and must meet accessibility standards to ensure an equitable experience for all members. So in the next slide, for the RFI timeline, we wanted to highlight that HCA wanted to better understand the virtual wellness offerings in the market prior to moving forward in a request for proposal or RFP. We felt that gaining this understanding would support us more in development of that RFP. As a result, we initiated the process to develop a request for information or RFI. We began development of the RFI in February of this year and posted it externally for responses in March. We used industry research along with knowledge of our current wellness program to develop that RFI. When RFI responses were received in March, an internal review committee comprised of members from contracts, benefit strategy design, and portfolio management and monitoring immediately began review of submitted materials. We met with vendors that submitted materials to hear more about their offerings and to allow time for us to ask questions to get more information about their programs. The written and verbal responses have proven to be extremely interesting and helpful as we have started development of the RFP. Now that the RFI has concluded, and you can move to the next slide, we began working on the RFP content. We're still developing the RFP timeline, so I don't have that specific information to provide to you today, but we are including technical and programmatic requirements in the RFP based on our knowledge of our current program, information gained during that RFI process, industry best practice information, and internal subject matter expertise, specifically surrounding information technology, contracting, security, and accessibility. After respondent information is received from bidders during the RFP process, HCA will score materials based on a set of metrics that are still under development. Once the written materials and, if applicable, presentation materials are scored, HCA will announce an apparently successful bidder, which will initiate contract negotiations and implementation activities. The new wellness contract is anticipated to begin on January 1st of 2024. So this does bring me to the end of my presentation. So in essence, the end of Kristen and my joint presentation. Are there any questions from anybody for either one of us?
Any questions from the board? All right.
Oh, no. Sorry. It took me a while.
I'm sorry, I didn't see you. Go
No,
on.
it took me a while to find the right places to click. I'm not sure who this for, probably Jenny, but regarding the RFI process and going forward with the RFQ, I guess it is process or RFP, has any vendor been able to provide data that demonstrates that their program actually shows a measurable and significant increase in employee engagement in terms of healthier diet options or activities, or healthier, being more active? Because I know there's agreement that people who are engaged in take care of their diet, are stay active, and otherwise make good choices in terms of their physical and mental well-being, are more productive, and it's better for everybody all around. What I don't know is whether going almost 10 years into this process, of whether Limeade or anybody else is able to show that their particular way of engaging with employees actually generates a change in behavior.
Yeah, I can speak to that. I can't speak to specific vendors and the information that they provided, but I think where you're going is the return on investment question, right? That is always a big topic around wellness activities. And that question, or questions surrounding how they would provide data that shows that their programs are, measurable and effective, was a big topic. And a lot of vendors have different approaches to that. With our vendor offering for the state of Washington, we don't do claims data integration. And a lot of vendors do point towards, using claims integration as a way to measure return on investment. That's not something that we're interested in doing at this time, but a lot of them do have year-over-year results based on that self-reported information that members provide during their well-being assessment, which shows areas of improvement, and we can tie a lot of that back to the engagement rates. We obviously get aggregate information. We don't get member level information, but we can look at, did we see the population year over year had decreases in their, their BMI as they've self-reported that. And we can tie it back to what weight management options or programs did we offer through that portal. Were those engaged in more, which would show a, somewhat direct correlation between those two. So we do have that we would have that information to tie it back to. And a lot of it comes back to how do we keep members engaged month over month in the programs to show that people are using it. And I know that wasn't as maybe a spot on answer to what you're looking for, but we're definitely, as we work through the RFI and the RFP, we're asking those questions to see where we can get, more measurable data to show the value of the program.
That actually, your response is very helpful. And I understand it's a very difficult thing to measure. So, and a lot of different things impacted, but I think, I think you, your answer provide a lot of useful insight on it. Thank you.
Okay.
Any other questions or comments for Jenny or Kristen? All right, folks, thank you so much for your presentation. Appreciate it. All right, next we've got our call for public comment. Is there anyone on Zoom that would like to provide comments? We're gonna, Dave, I'm gonna use your room to gather lists of speakers so that we can efficiently do this. Please click on your virtual hand if you would like to speak today.
So far, I see Fred Yancey. Doing a quick other check to see if we're missing any of those names yet before handing the mic to Fred. Won't be the last call. We'll do one more call, but so far just Fred. Fred, go ahead.
Good morning or mid-morning, Chair McDermott and members of the committee. Again, thank you always for the work you do. My concern is with retirees, and I clearly understand that retirees fall under the PEB arrangement, but they were brought up during this meeting. So my concern regarding the dental is the increased cost of any of these changes, particularly the crown change alone is a substantial cost. I think it would help members of the committee to, when they're engaged in these discussions, to also have a rate sheet in front of them so they could see what the current rates are, and then you can measure the impact. My understanding is, is according to the presentations, the rates could go up from $5 to $7 for each program. Crowns alone would be a $2.25 to $5.50. The $5.50 increase. This is a premium increase per month, and all of this assumes that the base rate of these plans will not increase. So again, my concern is with the added cost as it affects retirees, and I understand that that's more of a PEB issue, but should K-12 retirees be rolled into a SEB program in the future, then it would become a SEB issue as well. And maybe one solution is to allow a standalone dental plan with fewer benefits, which would lower the cost. I think that's all I have to say. And again, I thank you for your time.
Fred? I don't see anyone else at this point, so going once, going twice. Back to you, Chair McDermott.
All right. Our next meeting will be June 2nd from 9 to 2. Dave, any final comment? We're gonna, before we go into exec session.
Just at that June 2nd meeting, again, we will be in a hybrid meeting status. And so board members start to think about whether they're interested in attending in person and can start to let us know about that. We'll have Connie reach out as well, but just begin thinking about that option will exist as of June 2nd. We do anticipate that we will be describing some of the potential benefit design changes that our carriers have brought forward on the fully insured medical plans that could then ultimately be rolled up into the premium rate votes at the end of the season. So we'll begin describing some of those things at the next meeting. And we will also be presenting some resolutions related to the UMP high deductible plan. That's the HSA qualified IRS plan. We have gotten in the last week the notice from the IRS that the deductible level to be a qualified plan will need to be at least $1,500 as of 2023, and the current deductible for a single subscriber is $1,400. So in order to maintain that plan, there will need to be a vote to align with the federal requirement. So we'll have more about that next week, but anytime there's something related to deductibles rising, I always want to bring more attention to that sooner. So we will have a little bit more about the high deductible plan and some resolutions to maintain compliance with that we discuss next meeting. And so those are a couple of things that we'll talk about at the beginning of June.
All right, board members, any last comments or questions before we go into exec session? All right, seeing none. Executive session pursuant to RCW 42.30.1101I. The board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased health services as provided in RCW 41.05.026. The executive session will conclude no later than 12:30 p.m. Board members, let's go ahead and take a 5-minute break while we transition to exec session. We'll return to the public meeting after exec session to adjourn the meeting, and there will be no further presentations. So let's take 5, and we'll see you in a few.